জাতির একটি ভয়াবহ এবং একই সঙ্গে স্মরণীয় অভিজ্ঞতার দ্বারপ্রান্তে আজকে আমরা পৌঁছেছি। মহামারী প্যান্ডেমিক কোভিড-19 একদিক দিয়ে এটি আমাদের অনেক কিছু অভিজ্ঞতা দিচ্ছে, অপর দিক দিয়ে কেড়ে নিচ্ছে অনেক জীবন। তো এই দ্বারপ্রান্তে এসে পৌঁছে আমরা সবাই নানাভাবে বিভিন্নভাবে নিজেদের অবদানটুকু রাখতে পেরে আমরা কৃতার্থ। তো প্রথমে আমি স্মরণ করব আমাদের যে সমস্ত চিকিৎসা কর্মী, মাঠ কর্মী যারা কোভিড-19 আক্রান্ত হয়ে মারা গেছেন, তাদের প্রতি সশ্রদ্ধ অভিবাদন, এবং যারা ফ্রন্টলাইনে কাজ করছেন সবাইকে অসংখ্য অভিবাদন এবং অভিনন্দন। তো আজকে এখানে আমাদের যে বিষয়টি আমি বলবো সেটা হচ্ছে কোভিড-19 জন্য রেডিওলজি প্র্যাকটিসে আমরা কি প্রিপারেশন নেব তার একটি প্রপোজড গাইডলাইন বাংলাদেশের মতো একটি সীমিত আয়ের দেশে। অনেক কিছু হয়তো ডুপ্লিকেশন হবে, দেখা যাবে যে উন্নত দেশের সাথে আমাদের খুব মিল নেই, এবং আরেকটি বিষয় হচ্ছে যে দেখা যাবে যে কিছু কিছু জিনিস আমরা সেখান থেকে নিতে পারি, এবং আমাদের অনেক কিছু আমরা নিজেদের মতো করে নিয়েছি এবং প্র্যাকটিস করছি। সো এর মধ্যে ইতোমধ্যে যেটা হয়েছে WHO গাইডলাইন এবং আমাদের দেশের ডিজি হেলথের যে গাইডলাইন, সেখানে সোসাইটি অফ মেডিসিন, কার্ডিওলজি এনাদের গাইডলাইন গুলো ইনকর্পোরেটেড হয়েছে। তো আমরা আমাদের মধ্যে এখানে আমাদের সেক্রেটারি জেনারেল, প্রেসিডেন্ট, সায়েন্টিফিক সেক্রেটারি, অন্য সবাই আছেন, এবং মাননীয় ডিন মহোদয় শাহরিয়ার নবী শাকিল আছেন। তাদের মাধ্যমে আমরা চাইবো যে আমাদের রেডিওলজির প্র্যাকটিসের জন্য একটি গাইডলাইন প্রণয়নের জন্য। তো তারই একটি উপক্রমণিকা বা জাস্ট বিগিনিং হিসেবে একটা ফরম্যাট আমি দাঁড় করিয়েছি। এখানে সবাইকে ওয়েলকাম, আমরা যে কোনো কিছু এখানে যুক্ত করতে পারি। তবে মূল ব্যাপারটি যেটা মনে রাখতে হবে সেটা হচ্ছে একেবারে এটি আমাদের দেশের প্রেক্ষিতে তৈরি। ধন্যবাদ সবাইকে। COVID-19 and preparedness for radiology practice, proposed guideline in low resource country. The pandemic coronavirus disease we know presented in Bangladesh from the first week of March 2020. Due to increasing surge of the disease, many of the COVID-19 patients are being referred for imaging. Moreover, asymptomatic contacts are also being diagnosed with presence of COVID-19 pattern of infection. Through imaging, few of them found COVID-19 positive after investigation. So, in order to play important role in COVID-19 management in hospitals and diagnostic centers, there should be certain specific guideline for planning of diagnostic screening, prognosis of patient, for maintaining triage, management of the patients, to prevent dissemination of disease to other patients, to prevent dissemination among the general population, health worker, and planning of radiology workflow, planning for volume of work and how the measure of radiological workflow would be. We will discuss this process that have been implemented by some of the hospitals and centers of USA, Singapore, and China in managing the COVID-19 pandemic, as well in preparing for the patient surge. As well, we will discuss the possible measure could be taken in a low resource country like Bangladesh. Moreover, the structure of the future radiology practice could be planned accordingly. What University of Washington did, they have postponed all elective outpatient examinations like screening mammogram, screening for lung cancer, and others, so patient volume is decreased and potential exposure risk was reduced. Only hospitalized patients were rescheduled according to the severity of disease, and date of imaging is given accordingly. In order to protect healthcare workers, they have screened all patients who are admitted as inpatient for COVID-19 with RT-PCR, regardless of the reason for admission. The Department of Radiology and Imaging of University of Washington have declined 39 to 60% and 55 to 70% decrease in outpatient imaging volume. So estimated total volume of patient in 2 months time, they able, that is 14,923. It is University of Washington and its other hospitals which are accommodated within it. In order to protect healthcare workers, they have screened all patients who are admitted as inpatient for COVID-19 with RT-PCR regardless of the admission. So what is the benefit of this process? This causes reduced staff exposure, reduces the PPE use, stands for the plan, policy are taken and procedures which are directly applicable to imaging department in order to achieve sufficient capacity for continued operation during a healthcare emergency and to support the care of patient with COVID-19 and to maintain diagnostic, radiologic, and interventional support for the establishment of a health system. I cannot go to the next. So in context of a low resource country like Bangladesh, the radiology preparedness differs to some extent from the developed countries in respect of technological development, plenty resources, or availability of imaging instruments, skilled, adequate manpower, and well-developed hospital management system. So if I make a triad of radiology preparedness, the first wing is the hospital and clinic, the second wing should be the diagnostic and imaging center, and the third wing is the rural and semi-urban healthcare centers of Bangladesh. To me, several patterns of plans will overlap to each other. So what about the hospital and clinic? There must be telephonic triage with mild sign-symptom patients and triage to the outpatient department, emergency department, or triage to the radiology OPD with standard questionnaire should be given moderate to severe diseased patients. So there is a CDC guideline which tells us the current CDC criteria for person under investigation. Who needs the investigation? The patients with fever or sign symptom of lower respiratory tract illness, such as cough or shortness of breath, and any person, including healthcare workers, who has had close contact with a laboratory confirmed COVID-19 patient within 14 days of symptom onset, they should be imaged. Number 2, fever and sign symptom of lower respiratory tract illness that require hospitalization, and a history of patient or anybody from the affected geographic area below the list within 14 days of symptom onset. The list includes China, Iran, Italy, Japan, South Korea. And number 3, fever with severe acute lower respiratory tract illness such as pneumonia, ARDS. It required hospitalization and without any alternative explanatory diagnosis such as influenza. These patients need imaging. When these patients meet the criteria above, we should ask them to put on a surgical mask and place the patient as quickly as possible into an airborne isolation room, which is maintained with the negative pressure in the emergency department, or at least a private exam room. We should keep the door closed. And institute airborne and contact isolation plus eye protection. All healthcare personnel entering the patient's room should be wearing either N95 respirator with eye protection such as goggles or a face shield, a gown and a gloves. Consider the sending of a nasopharyngeal swab for routine respiratory viral panel testing to evaluate for community respiratory viral infection such as influenza. And immediately we should contact the hospital epidemiology and infection prevention to give aware about the COVID patients. So the symptomatic patient in isolation room or triad, if they are less complicated, they might be sent for isolation ward for further investigation, such as the RT-PCR and, if needed, the portable X-ray. And the patients who are admitted with moderate to severe disease who fit for the criteria of admitted within the yellow or red zone, they should be sent for the portable X-ray in an isolation room. So this is the workup and radiology in COVID-19. This is the flowchart of University of Washington. It tells about COVID-19 suspected patient. If they need for COVID screening, then do the RT-PCR test for screening, then no need for imaging for screening or evaluation of COVID-19. And if the COVID-19 suspected patient, alternatively diagnosis being considered that would affect the management, such as having severe fibrosis or pulmonary embolism, they should send to the portable imaging. If possible, we do the portable imaging. If not possible, we send them to the radiology inpatient department. Other COVID-19 suspected patients who are emergent need for any imaging diagnosis unrelated to the COVID-19, that is acute stroke, RTA, they should be sent for portable imaging. If possible, do the portable X-ray through the isolation room glass, and if not possible, then send it to the radiology and imaging department. Here, the critically ill patients should be having very, very strong precaution. And there should be some key points. The key points are: ensure limitation on patient travel. If imaging is available at clinic, please perform imaging on site in coordination with patient visit. Please avoid sending patient to imaging site with high volume patient, critically patient, or immunocompromised patients. So they are inhibiting the critically ill and immunocompromised patients to send during a COVID-19. For imaging, please consider whether imaging will impact patient management prior to ordering. And there are some aerosolized procedures like lung biopsy, lung ablation, chest tube, bronchial artery embolization. This should be done with heavy precaution. So what should be the plan of imaging? There should be a triage tent screening prior to imaging procedure. All patients are screened at the hospital entrance for COVID-19 with a second layer of symptom screening at the radiology front desk. And then portable X-ray should be done near the triage tent with a portable X-ray through glass door. I will show you. Or if the isolation room is not available, then from 10 to 15 feet away. Appropriate indication must be there for elective imaging so that it plays strong role in patient management. X-ray, ultrasound, CT, MR to see the severity of disease progression, such as pneumonia to ARDS or pulmonary embolism, MR to detect any infarct, ultrasound in very few cases to rule out other causes of hepatitis. Routinely, it is not advocated by the CDC to see the pleural effusion. So inpatient imaging in the department. COVID patient and symptomatic patients with respiratory distress must ensure limited travel. The imaging should be scheduled in a specific time to reduce the patient burden and viral load. Critically ill or immunocompromised patients should not be sent for imaging until otherwise it is life-saving. Patients undergoing aerosolized procedure, I have previously told that lung biopsy, pleural drain embolization must be taken with proper droplet airborne contact precaution. So this is the University of Washington. They maintain this isolation room. This is a negative pressurized room, and you can see the ordinary glass window. So patient is inside the room, and this is the portable X-ray, and they are doing the X-ray AP through the small window. So what about the technologists? You have known that technology should don with the appropriate PPE, that is appropriate gown, appropriate gloves, eye protection, mask, everything is known to you. And what about the room I have mentioned in the portable X-ray room? This is a semi-isolated antechamber consists of wheelchair on which patients sit upright facing the glass door or a glass wall. A nurse or assistant with proper PPE place double-bagged X-ray cassette behind the patient. Technologists outside the room do the positioning via the speakerphone, and after giving exposure through the glass window, nurse or assistant disinfect the outer bag of the cassette and bring it to the room door. The technician disinfect inner bag, remove the cassette, and process. The plastic bags are disposed. So what should be done for CT, MR, or ultrasound? Telephonic triad and appointment for COVID and non-COVID patients in separate time schedule should be performed. If COVID positive or suspected patient need to send, the clinicians must inform the department previously and take specific appointment in a fixed time, preferably after evening and around after 5 p.m. so that all the normal patients and normal scans has completed already. Any patient come to CT, MR, ultrasound must be attended by a doctor or nurse for triage on the front desk. Questionnaire need to be filled up. Detailed history must be taken with relevant papers. Patient's temperature need to be recorded. COVID positive patient and suspected symptomatic patient must be sent with mask. COVID positive ill patients can be sent with a this way stretcher along with a protective cover of fiber or polythene. This sort of cover first used in the China, then in the Korea, Hong Kong, and nowadays it is also used in Bangladesh in several centers like Square Hospital and others. And also in the CMH and some air ambulances. Patients should wait in an isolation room in imaging waiting place, preferably maintained with negative pressure. So you may ask, which means we can maintain the negative pressure? We can maintain some local resources by exhaust fan and placing the fans underneath and at the floor level. Specific time should be given for each appointed patient after adequate interval so that overcrowd and contamination cannot occur and adequate time for disinfection can be gained. Ideally, 1 to 3 hours should be given in between patients, but it can be reduced with optimum precautions. So, CT, MR, ultrasound assistants with proper PPE should attend patients for positioning and cover the examination bed with disposable clinical tissue. No attendant should be allowed remaining with the patient within the imaging room or waiting isolation place. After each scan, removal of disposable tissue, then whitening by disinfectant, patient bed, it is wiped by disinfectant, parts of the machine may be disinfected by appropriate disinfectant. Some of the institutions in abroad, they use the hydrogen peroxide vapor after doing scan of COVID patients. Ultrasonography and Doppler rooms can be arranged using local resources. Separate fiberglass, thin glass, or polythene sheet from the ceiling to the floor can be used, extending from door up to the machine, thus completely separating patient space from machine and the doctor. patients should wear mask. Ideally, ultrasound room should be with negative pressure for COVID patients, but using local resources I have told previously. Gel impregnated ultrasound probes can be covered with vinyl material in case of risk of heavy contamination or for intervention. You can see the ultrasound room and polyethylene, or it can be used the fiberglass. Here thin polyethylene used, and there is a gap, and I would advocate that if we can seal this place like this polyethylene, through which the hand we can hold the probes, so the compartment is totally sealed with air, so no air passage is between the patient space and the doctor. Proper disinfection of patient bed instruments should be ensured. Proper sanitization of doctor assistant should be ensured after each scan with appropriate doffing. So this is the gel, and in case of severe contaminated patient, or when you will do any procedure of intervention, you can cover this with a vinyl gloves or vinyl material and given the gel above. So in this way you can do. So this seal can be done with this sort of instrumentation. So what is the recommendation? Our recommendation is formation of COVID crisis management team in hospitals incorporating the radiologist. Till now, we don't have radiologists among the COVID crisis management team. There should be establishment of hospital infection control department with well-trained staffs for hospitals, clinics, and diagnostic center. Till to date, we had not yet the hospital infection control department, but a few days ago I have seen an order from the ministry that in each hospital the hospital infection control department and team should be formed. Arrangement of infection control hands-on training program. Workshops can be done for all hospital employees. Ensure all employees aware of infection control, ensure adequate PPE and use of minimum required manpower to maintain the social distance and reduce the mass exposure. For this reason, we may do the working of teleradiology, and through remote workstation should be encouraged, and minimum employee, minimum assistant, minimum radiographer should be exposed. We need to develop of a detailed operational plan along the hospital clinicians, hospital management authority, as well as with the central system of Director General of Health Services of Bangladesh in order to face coming surge. We haven't already obtained a surge. In order to face the coming surge of COVID-19 epidemic, we need a detailed operation plan. We need to review, we need to upgrade and practice protocols for imaging, disinfection procedure, and maintenance of health security measure for all employees. We need to define the newer role of imaging in a resource-poor country for isolating the contacts. As we have paucity of RT-PCR, screening by HRCT might be fruitful for isolation of asymptomatic, less symptomatic patients in red zone area. Initially, when there were paucity of RT-PCR in China, they used this imaging for diagnosis. They used this imaging to isolate the bulk of the patients in order to reduce dissemination of the disease. And at last, all radiology room, places, waiting room, isolation should be marked with appropriate images, signage. These are the signs so that patients are aware of what to do. Continuous demonstration could play important role through TV monitor or computer monitor in the hospital or media like TV channels to make people cautious and aware about the disease dissemination and behavior in the hospitals. In a pandemic management, temporary rules might be obtained, such as compulsory mask wearing, it is already in Bangladesh, maintaining social distancing, gathering of more than 10 people should be punishable. And in America, there are phase 1, phase 2, phase 3 of opening of lockdown. So we can follow, that is in social distancing, at first 5 people, then 10 people, then allow 12 people, then allow 20 people in this manner. In this way, we can reduce the exposure. And this signage should be in the radiology department that stop, don't go, please ask the nurse before enter, please wear mask, please clean hand, and please keep the door closed. So this is all about. Thank you very much. Thank you for patient hearing.